Good morning, and thank you for attending. This part 2 of the course is on evaluation report for eye gaze, so the report writing phase of your evaluation. My name is Rachell. I'm a speech-language pathologist, and I've had several years of experience with eye gaze evaluations and have been doing them for the last 6 years. So let's get started, and I would like to know more about who you are. So if you'll please let me know what your primary role is. Wow, so I see we have some AT specialists and occupational therapists, speech-language pathologists, and we have 2 others. Just curious for 2 others, if you don't mind using your Q&A and just letting me know who you are or what you do. And that will only show up to me. Thank you all for joining. My next question will be, this is part 2 to this presentation. I just want to know if you were able to attend the first session on eye gaze evaluation. Okay. So a few of you did, and some of you didn't, and that's okay. We're going to actually do a very, very brief review of the eye gaze evaluation session that was part 1 before we move into the report writing. Okay, so thank you all for answering that question. So challenges to eye gaze evaluations and report writing. The most common challenges that I've found is while you're doing your evaluation, something doesn't work. It doesn't work. We're going to get into what I mean by that in just a moment. With the writing, oftentimes we either have too much information or we have too little information. Sometimes there's conflicting information, and we want to make sure that we steer clear of that. And often the challenge is that the report process is way too long. Okay? So it doesn't work in streamlining report process. We'll kind of talk about those things. And then here in the middle, as part of your evaluation report, we have to be careful if we put too much information. We have to be careful if there's not enough and if it's conflicting information. So those are some of the things that we're going to go over in this presentation today. So it's evaluation time. And what are some reasons that certain things or it doesn't work during your eye gaze evaluation? So this is a little bit of a review from last time. Remember that to check your input settings to make sure that your selection method is correct. So you're trying out eye gaze, it doesn't work. Well, did the selection method actually say eye gaze? Sometimes on certain devices, there's more than one place to put that input method. So you need to make sure that you're familiar with the device and you know how to change it. And if there's more than one location or more than one area for that setting, that you've checked it and make sure that it says eye gaze instead of direct select or mouse emulation. Okay, that's what a selection method is. And another thing that you have to be careful of is that some eye gaze devices will allow the person to go through calibration and that selection method is not on eye gaze. Okay? So some devices allow for calibration or allow you to go through the process, and you haven't actually turned it on to eye gaze. So be careful of that. Another reason why it doesn't work could be your activation method setting. Maybe the person is unable to dwell, so they need to change to blink or to eye gaze with a switch. So you might have to change that. Positioning could be an issue. Lighting. So sometimes if you're in a brightly lit room with fluorescent lighting, you might have some trouble with certain eye gaze devices. Eyeglasses, whether the person is wearing bifocals or trifocals, may be a reason why it doesn't seem to work. What can you do? Can you dim the lighting? Can you dim or close the blinds in the room to see if you can reduce the glare off of those glasses? And then traditionally, bifocals and trifocals have an issue of not working. So just be careful. I think with newer technology, every time an eye gaze device, the eye tracker is updated, you're going to get ones that work better with bifocals and trifocals. So this may not be an issue for very much longer, but just know your devices and know which ones typically work better, and make sure you have those on hand to try with a person who's wearing bifocals or trifocals. Okay, calibration settings. Again, we talked about this last time. This could actually affect your evaluation. So if the person is having trouble with their calibration, is it something that you can do? What tools built in to that device can you change to make the calibration more successful? And again, that was talked about last time. So one important thing that we often forget is that clean and clear screens, okay? So use your microfiber cloth, clear that screen where the eye tracker is. Sometimes our fingerprints get there, and that's going to maybe make it not work for you, or for the person that you're evaluating. So just make sure that your eye gaze screen tracker is clean and clear. Okay. So again, a little bit more of a review from last time. Here's your eye gaze evaluator checklist. You want to make sure when I'm using the word familiar, I'm meaning well acquainted, you're well versed. So you're familiar with all of the devices and settings that you have to access, and those that you don't have access to. All of the devices and settings that you have access to in your facility or your classroom or wherever you're evaluating the person, and those you don't. You have to be familiar with both. So maybe you're borrowing a device that you don't normally have access to that device, but you're borrowing it for this evaluation. You still need to be familiar with all of the settings in case you need to change something. I'm familiar with devices approved by insurance and those that are not. It's very important because some folks will choose to go with a device that is not an insurance-approved device, such as Medicare or private insurance or Medicaid may not pay for a PCI mobile unit because it has a Surface Pro attached to it. But being familiar with it, being able to tell them about it and show them, it's really up to the person or the family if they want to pursue that. And it's still something that you can try as part of your evaluation. And some people may weigh that decision if their copay is so large that it's almost the same cost. They may want this over the Medicare or insurance approved device. Okay, make sure you're familiar with positioning of all the mounts that you're using during your evaluation. If you have more than one mount, please be familiar with it. Make sure that you have information via website or company brochure on device mounts and devices that you don't have access to in your facility. So you don't have the device or the mount, you don't have a way to borrow it, make sure you're still familiar that you can still produce the information for the patient to read and look at. Know how to contact tech support for the devices that you're demonstrating. That's going to be really important during your evaluation. It can actually speed things up during your evaluation. Make sure that you can troubleshoot the evaluation for each device that you're demonstrating, like the calibration troubleshooting that we discussed last time. Make sure that you can program and edit pages as needed per device that you're going to be demonstrating during that evaluation. Make sure you have a camera ready and available. Why do you need that? So you could actually video something. And last time we talked about certain tools like Look and Learn or MyGaze has, I think, uses IntelliTools. And we talked about Tobii Dynavox iGaze Evaluator. So those have built-in recordable features, but maybe you don't have access to those things, so make sure you have a camera ready. Also, you need a camera that snaps photos when you're dealing with a power wheelchair and you're going to have to mount that device, the iGaze device, to the wheelchair. So make sure you have a camera ready and available, and you're wanting to take a picture of both sides of the wheelchair, and you want a picture of the seat rails as well, because you never know when a mounting company is going to ask you for such pictures before they will recommend the right product for you to use to mount. So good, that's just an overall reminder checklist, and now we are ready for the funding report. Okay, so before you start your evaluation, ask yourself, what are we doing as evaluators when we're doing the AAC evaluation? We're really feature mapping. We're matching features of the device to the person, right? So you're going to have to really know the person very well. And most places, whether you're a school, whether you work at a school or a facility or private practice, you're going to have some form of a health history questionnaire or a client information form or student information form. You want to make sure that your questionnaire really highlights their current medical status and history. And you want that information to be relevant, okay? You want to make sure that you know the history of the person's use of previous AAC devices or strategies. You want to know what their hearing and vision is like. That's very important. All of this will be important to that report. Mobility component. So you want to make sure you know if they're ambulatory. And if they are, do they need assistance? Or if they're not ambulatory, what are they using for assistance? Before you start, you want to know the rules of your funding source. And the only way you do that is knowing what the person has. Who is going to be funding the device? Is it Medicare? Is it Medicaid? Is it a combination of both? Is it private insurance with Medicare? All the different funding sources have different rules for your report writing. So you want to have a copy of those cards and know exactly who you're going to be turning this into so that you can write your report accordingly. You want to know the funding packet requirements of your DME provider. That's going to be really important. So when you're turning this in to the eye gaze company, the company that the eye gaze will be purchased from, you want to make sure that you know what their requirements are. And normally, they have some type of a funding packet or a checklist that says these are the documents that are needed. And we'll get into a little bit more about that. So let's talk about funding sources. DME provider versus funding source. When I say DME provider, I'm talking about the durable medical equipment provider, so the device company. So if you're going with a new eye with an accent device, that's PRC. AbleNet has an eye gaze device. Tobii Dynavox has eye gaze devices. So you just want to make sure you know exactly who you're turning this report into. The report gets turned into the DME provider, not the funding source. So the funding source is Medicaid, Medicare, private insurance, and that's not who gets the report initially. You're turning that report into the DME provider. Each DME provider will have a funding packet and their own requirements. Most of the time, it's going to include a client information form. This is more demographic information, insurance. Sometimes a company's client information form will ask for information like their diagnosis, their previous device use. Often there's, it looks like I have a connection error, so I hope that you guys can still see everything.
Everything looks fine.
Okay, thank you. So we're going to keep going right along. You'll have a release form, an assignment of benefits or responsible financial responsibility form. There'll be a copy of insurance card. Your report is going to be part of that funding packet. A prescription from the physician. This typically is always going to be the physician who wrote or gave you the referral for the AAC evaluation. Okay? So you most of the time can't have a different doctor who did not refer the person sign off on your report and prescription. It needs to be consistent. It needs to be the same physician. Additional items may include a letter of medical necessity. That's what LMN stands for. And that letter of medical necessity would be from the same prescribing physician and referring physician. Okay? Additional items may be according to the funding source, may ask for something additional. All right, so I want you to tell me yes or no. A DME provider can tell you how to write your report. Okay, I'm getting some mixed results. A lot of you are telling me, no, they can't tell you how to write a report. And we're going to go over the answers to this in a moment. We're going to ask a few more questions, and then we're going to learn the answers, okay? The next question is, a DME provider can tell you what to write in your report. Is that a yes or no? And some of these questions are a little tricky. So I'm kind of getting more closer to half and half on that. Okay, let's go to the next question. Okay. A DME provider can make suggestions on best practices for documentation. Is that a yes or no? Good. I'm getting a lot of yeses for that one. All right, last question. A DME provider can refuse your report, or they can have you make changes to it prior to submitting. Yes or no? Okay. All right, so let's go on and find out the results or some of the answers. Okay? So I'm going to mark on the screen here. The first question was, a DME provider can tell you how to write your report. And this is all in the definition of the word how. So true. They can tell you how Medicaid or Medicare or private insurance is going to accept it or not accept it. So just an example, when I first started writing reports, drop-downs were acceptable. So check boxes and drop-downs were acceptable. Now it's not by Medicare standards. So a DME provider has the right to look at that report and say, you can't write it that way. You have to write it in a narrative format. So yes, they can tell you how. Okay? Can a DME provider tell you what to write in the report? That is false. They cannot specifically say, you have to write it this way. You have to write this sentence. They are not supposed to tell you exactly what to put in your report. But how and formatting and what Medicare does and doesn't accept, or Medicaid does and doesn't accept, the how, they can tell you that. Specifically what to write, they cannot tell you. A DME provider can make suggestions on best practices for documentation. I think everyone got that one true. So they can say, that's a red flag. Medicare or Medicaid, they're not going to approve that. They can tell you red flags. They can help you make suggestions on best practices. They can't exactly tell you, you have to say something this way. You have to word it this way. If they can tell you how you can't word it, they can do that. Okay, a DME provider can refuse your report or have you make changes. This is true. When you are submitting to a DME, more cases than not, and maybe over 90% of the time, that DME provider has their own Medicare, Medicaid reviewer in-house. They actually are the ones that you are submitting your report to and paying for that device. And oftentimes they don't submit to the actual Medicaid or Medicare or funding source private insurance until later. And so they do have the right to tell you we can't accept it, because it's their money essentially that they're putting up for that's hanging in the balance while they wait on that funding source, which typically could be anywhere from 6 months to a year or two later before they find out if the funding source approved or denied. So they have a responsibility of making sure that everything that you're documenting is following the guidelines of the funding source, and they have the right to tell you when it's not. All right, you guys did really well. Let's keep going. Let's talk about Medicaid. Each state is different. Some is going to require a particular format or form. So you need to check with your own state. So most of the time it's the DHS website. Find the form, or you can check with your DME provider. Sometimes the DME providers are well versed in a certain state, but you can check and see, is there a certain format or do I create my own? Some states allow you to create your own format. Some say, nope, you have to use our dedicated form. The definition of what a trial is or the need for a trial period changes. Okay, so some might say that trial period is during therapy. Some might say that trial period has to happen at home and in therapy. And some might put a time limit on the trial period. So whether you're trying something for 2 weeks or 30 days, certain funding sources are going to be different. So make sure you check with your state. And sometimes your DME providers are a good resource of knowing what hasn't worked in the past. Data collection for that trial, for Medicaid especially, is important. And that's probably going to be just about everyone's Medicaid, no matter what state you're from. Standardized versus non-standardized testing. As you know, when you're working with a child or an adult with lower cognition, you may not have especially those with communication disorders that need an eye gaze device. You probably don't have access to any standardized testing that you're able to do. You can't do a golden Christo on someone who needs an eye gaze to speak, right? So just know what your funding source is required, what they're requiring you to document. Sometimes the funding source just wants you to state under the standardized section that you were unable to get standardized scores for this reason. Okay, it's just a simple sentence stating that. And then non-standardized testing, they're going to want your clinical observations. Okay. Letter of medical necessity is not always required, but it may be required in your state. Find that out. And again, that's going to be from the physician. And then who signs the report? If you're evaluating as part of a team, some sources may want every single member of that team to sign off. Meaning if an OT was part of your team or PT, that they may have to sign off on the report. And some states are only going to want the speech-language pathologist to sign off. So that's going to be a constant. Speech-language pathologist is going to be a constant person who signs these reports. But just be wary of if a certain state requires the whole team to sign off. Okay. Talk about Medicare and private insurance. Medicare review is regional. I'm going to go to another slide right quick. Okay? So for me, I'm in the state of Virginia currently, okay, and I'm in this region, jurisdiction C. When I lived in Minnesota and I was doing these, that's a whole different region of review. So guess what? They have their own rules. Across the board, Medicare and private insurance follows Medicare guidelines. Across the board, the rules are going to be the same. However, there might be slightly different things about report writing that you're going to find different in the different jurisdictions, okay? So it's important for you to look at what jurisdiction you're in and find out maybe your DME provider has more information. I'm going to give you an example. In Minnesota, we were allowed, when working with a very progressive disorder, such as a progressive form of MS or ALS, we were able to document the word weakness with no problem. However, jurisdiction C according to one DME provider, is having trouble with the word weakness in reports, and they've been seeing some denial. I still think, because especially with ALS, the word weakness is actually a symptom of the disease because your muscles are getting weak, that you can justify needing an eye gaze for that reason if it's worded correctly. And so they don't want you to use the word weak or weakness in jurisdiction C at the moment. One thing with these jurisdictions and Medicare reviewers, every few years things change, so just keep checking back when a new rule pops up. So they don't want you to use the word weakness currently. Well, how do you define that? Just define it in another way, because it is a symptom of the disease, and so you have to be able to describe that in another way. So don't use the word weakness, but still describe what's going on with the patient. So that's just an example. I've asked, someone in another jurisdiction, are you hearing this? And they've said no. So it's little tiny things like this that you may find a little bit different according to where you live. Let's go back to the previous slide. Some rules will be across all regions, such as the rule about not using drop-down boxes anymore. That was a really easy way to develop a template for your funding report, and unfortunately they want more of a narrative. Now, in a year or two, who knows? Medicare may change their mind, but keep in mind that if your funding source is private insurance, they're going to go with what Medicare wants. So right now they want a report format that doesn't look checkboxy, doesn't look like drop-downs. They want it more narrative looking. Okay. Trial period or definition of a trial, again, make sure you understand what that looks like. When the person is a previous device user, so they've already been using an AAC device for a long time, it doesn't matter if they've never used eye gaze before, but if they have been a long-time user of the AAC, then you typically do not have to do a trial with Medicare as far as anything outside of your therapy. So as far as them getting a trial device and it being at home with them for 30 days, typically is not required. There are going to be the exceptions to the rule, such as when a person has a private insurance plan that is managing their Medicare. So in the state of Virginia, where I live, it's Humana, I think, is an example of a managed Medicare plan. And so they sometimes will require a trial of someone who needs a device that's separate than what you're doing during your evaluation and your treatment and therapy. Okay, the standardized versus non-standardized testing with Medicare and private insurance, you usually can really just document your clinical observations, and we'll get into what those would be. Letter of medical necessity, sometimes it is required, and when I'm dealing with several chronic patients at once, or I'm an entity that I'm using over and over again, such as a neurologist's office, I may just implement doing this letter of medical necessity all the time, so that it doesn't come up as something later that's going to delay the process. Okay, this face-to-face is very important. The notes from the physician need to state that the person that needs an eye gaze device or needs this type of AAC evaluation, that they have a severe communication impairment. Okay, who signs the report? Typically with Medicare and private insurance, it's just going to be the speech-language pathologist. Again, If your DME provider is telling you something otherwise, go with what they say because they have the right to tell you that. But typically it's going to be just the FLP. Okay, so I'm going to answer a question. Okay, so the first one looks like it's more of a comment. Someone was clarifying that an eye tracker is just the access method and not the SGD. So yes, I am familiar with that. And so I'm sorry if I have confused anyone. The eye tracker is an accessory, and we're going to get into that when we talk about more about the funding. Okay? Thank you. Okay, and then we're going to get into justification. So someone has also commented, you cannot recommend eye gaze if other less costly methods can be used. So yes, I am familiar with that as well. So you're a little bit ahead. And we are going to talk about ruling things out. But this presentation is with the understanding, if you attended last time, that you have ruled other access methods out. And if you haven't, then you can't start with eye gaze. You do have to investigate other access methods because in your funding report you will be needing to document on why you ruled those things out. So thank you for your comments, and if you have any more or you have actual questions, please continue to type those. Okay, so we're going to go on and talk about the funding report. So communication, sorry, I skipped a slide. You want to keep good records during your evaluation sessions. Again, when you're evaluating for eye gaze devices, you will be typically not choosing that in one treatment or evaluation session. Sometimes it's going to take several, unless you're working with a literate, cognitive adult, and sometimes even then it might be taking you a while to do the evaluation. So you want to keep good records, especially if the person's coming in over a period of time. The largest area of importance in documenting for an eye gaze device or an eye gaze accessory to your SGD is other access methods and why they do not work. That is going to be a huge chunk of your funding report. So you need to document and keep good records on when you're observing another access method and why that isn't appropriate for the person. It's okay to be repetitive in your report as long as you are consistent in your report, okay? Evaluation report formatting. For the purpose of this session today, I'm going to go over a typical Medicare insurance type format when I'm talking about what goes into the report. And I'm doing that because that's going to really hit on anything that a Medicaid would also require. So just know that I'm kind of looking at it from that perspective. If you're a school-based speech-language pathologist and you're involved in a school that is helping to pay, or the school is going to be maybe reimbursed for that device later, this particular information is still helpful, but your school probably has their own format of things that they require you to put in the report. So just be mindful of that. So communication impairment. You want to make sure that the medical status that you're reporting on is relevant. and that you're talking about their history, their therapeutic program. The communication impairment description has to say severe, okay? It doesn't matter what the communication impairment is, if it's apraxia or aphasia or dysarthria. You want to make sure that you're stating that it's severe. Now, remember, it's the communication impairment that you're talking about being severe. Severe does not, or communication impairment, does not only mean intelligibility. Some people stop here and they don't go any further. Someone can be intelligible but still have a limited expressive speech. Their rate of speech may be affected. Breathing and coordinating of breathing and speaking together. Their ability to phonate. All of these things are included in what communication impairment is. So any of those things can be severe enough for you to warrant needing an AAC device and with an eye gaze accessory as well. Okay, so the use of low-tech strategies, books and communication devices, communication books or boards, anything in the past, you want to make sure you're able to document that. Prior level of function, current status, okay, their prognosis, is their anticipated course of impairment stable? Is it declining, like with ALS or progressive disorder? You have to state in your report that their communication is improved with the SGD, and if it's an eye gaze that you're going with, accessory, you have to state that, you know. That's what they're looking for. They're actually looking for that statement in your report. So vision, okay, if it's when you are ruling out, when you're ruling in an eye gaze device, accessory, you have to remember that under where you're documenting about vision, you're going to talk about positioning, that the vision modification is positioning of a device appropriately to allow for proper access to the eye gaze accessory. Okay? If the person has a vision problem, maybe they need really larger size buttons, you have to list that as a modification. Physical status, functional, meaning ambulatory. And here's a question that I like to ask, and I want to know your opinion on it. Can I recommend an eye gaze accessory to the SGD for a person that is still ambulatory? So give me a yes or no. What are your thoughts? Good. I'm so happy to see that I'm getting a lot of yeses. So yes, you can recommend an eye gaze accessory to someone who's ambulatory. Because ambulatory, really, when you're documenting on whether someone is ambulatory or not, it's really referring to their wheelchair, or, you know, to a person who might need a way to transport that device because they can't maybe hold and manipulate the device at the same time. So this ambulatory really relates to the mounting issue in your report writing, okay? Upper extremity function, that's going to be important because you're noting what method is appropriate. You're ruling out, if you have to rule an eye gaze, you have to rule out other methods of direct selection. Scanning is not direct selection. It's Scanning is the only method of selection that isn't direct because there's extra tools involved. But other methods of direct selection is touch. It could be joystick or mouse simulation or something of that nature. You have to rule all of those out and tell why you did. How are they going to be using the communication device in what position? That's going to go back to the mounting as well. So that question is going to relate to whether a mount is medically necessary. Okay. The report, usually funding sources want you to say, with this modification, the patient possesses the physical ability to effectively use an SGD and required accessories. You know, and if you know eye gaze is the accessory, you don't have to say required. You could actually list it there wherever you're going to put that statement in your report. There is not a rule about the flow of reports. I have one question that came in that says, does insurance allow OTs to write reports for eye gaze, or does it have to be an SLP? And specifically asking about Medicaid reimbursement. The speech-language pathologist definitely has to be the one to submit the eye gaze, the report or the funding paperwork necessary for the purchase of the eye gaze accessory. However, some Medicaid forms, if an OT was involved as part of the evaluation team, some Medicaid forms will require that OT to sign, and some don't. So just check with your state. That was a very good question. If I haven't gotten to your question yet, I will answer it before we conclude. Okay, so we're going to move along with the report writing. Under your comprehensive assessment section, you're going to make sure that you're talking about language and cognition. If there's any standardized testing, make sure you include it there. Clinical observations are going to be your expressive, your receptive, reading, writing, attention, memory, ability to learn. Were they able to learn a navigation tool or technique? You know, you showed them one time, or they were able to do so independently. What you want this section of your report to reflect on, do they have the expressive skills or the receptive skills necessary to use that device? You know, what if they can't read? Does a person have to be literate to qualify for an eye gaze accessory? No, they don't. We'll talk about what feature of the device or language system is most appropriate for that person with that eye gaze accessory being used to access it. Okay? The patient possesses cognitive linguistic abilities to effectively use an eye gaze accessory to communicate and achieve functional communication goals. So that's just a sample statement. Again, your clinical observations, just the conclusion must be, yes, they're able to use it to effectively communicate. Not just the SGD, but include the eye gaze accessory in that statement. When you're talking about their daily and functional communication needs, you're going to be talking about their medical needs. You're going to talk about their communication partners. Remember, Medicare, private insurance, they're going to only really care about things that happen in the home, okay? That's their Medicare is their large or chief concern is how is this going to help them function within their home. So if you're working with someone who is in the home with a lot of caregivers, you're going to talk about those caregivers being their communication partners, okay? Communication environment, that's going to be really, really important. Medicaid, young students that you're working with, young pediatric population, you want to make sure that you talk about all the environments, school, home, wherever this child may be. Maybe they have a lot of medical appointments. Put all of their communication partners' environments in your documentation. Use words like this is going to help them remain in their least restrictive environment. That's okay to put in your report. Why does low tech not meet their daily communication needs? With any dynamic display device, you're going to have to document on that, and it's going to be even more important for you to have good, solid evidence when you're talking about an eye gaze device. And if you're working with a progressive disorder, such as ALS, you're going to have to really document why something like writing isn't going to benefit this particular person. Your rationale for choosing a device. You need to try more than one device. You need to document that you have. You need to state why you ruled a certain device out. Did they not understand the language system? Were they not able to calibrate to that eye gaze accessory for that device? State why the recommended device was selected. Use examples in your rationale. This is where you should be putting, especially in the Medicare and insurance format, where you should be putting your examples of device use during the trial or treatment session, and you've taken a really good note. Really write down everything that they were able to say with the device and who they were talking to. Did they do this independently? Did they do it with very minimal cueing? Put everything you can in your rationale. Tell how and which selection method was most useful. They were most successful with using blink versus dwell, okay, for example. You have to state that your SGD with eye gaze accessory is the best method of functional communication for this person, and then tell why. Okay, so if you were ruling out scanning because the person could not get the timing right due to their range of motion, their limited range of motion or no range of motion, they couldn't, scanning was not successful. On the flip side of that, if eye gaze was the most successful thing that's going to help them be a functional communicator, then you have to tell why. You can't just state it, but tell why. List features needed as determined by their language skills and their cognitive abilities, as well as their vision and hearing needs. So again, if they need larger buttons, list that as a feature for that device that you are funding or recommending. I feel like I'm zipping through this, so let me know if you have any questions. So remember, and some of this slide I got from a webinar that Toby Dynavox did, particularly this. For an SGD to be chosen as reasonable, Medicare doesn't want to pay for a Ferrari if a bicycle will work. So if a client cannot use it, why should Medicare pay for it? So if scanning works for a person, a switch, and you find something appropriate, then no. And that's going to go for Medicaid as well, not just Medicare and private insurance. If an alternative access method works for the person and they're successful with it, and they have effective and functional communication at all times with it, then you cannot get the eye gaze accessory approved. Okay? And I'm just going to play devil's advocate and flip this around. If you know, and I'm going to use ALS as an example again, If you know the person cannot use an access method, it's not the most functional. Maybe they can only use it an hour out of the day. If they cannot use it, why should Medicare pay for it? So why are you recommending it, would be my question. If they can only raise their arm to hit that button or use their elbow, and they only have strength to do that for a few minutes during your evaluation, but it's nothing that they can keep up for the rest of the whole day because of their weakness and fatigue with ALS, then you can't recommend it. So just because someone can demonstrate during 5 minutes of your evaluation that they're able to do something, you still have to ask, is that method functional at all times? Because otherwise you're limiting their communication, their ability to communicate. So be thinking about those things as you're thinking about ruling eye gaze in. Be really understanding of what the word functional means. Functional should not mean that they can only use it with a certain environment or a certain person or a certain time of day. This needs to be in an emergency in the middle of the night. Can I still use this method? Or if I have something that causes me to be weak, can I still use this method? So remember that in your documentation. All right. Medicare, Medicaid, private insurance will not pay for what will happen in the future. So you cannot say, in the future, this person with MS will no longer be able to use their hands for writing. You can't say that and expect an eye gaze accessory to be funded. Okay? That will be a denial. You have to prove what's the most functional method now. And remember, at all times, least restrictive environment with all communication partners. So you also have to ration out each accessory. We talked about eye gaze, and now you have to remember that mounts are also considered an accessory. So you might have to talk about the comments that you taught when you talked about those physical characteristics. If there is a switch mount involved, you'd have to still have a rationale for that. And I'm going to go quickly back to switch mounts and just say that if you're recommending the eye gaze accessory with a switch, most funding sources are going to say, the switch itself is an access method, and they're not going to pay for both the switch and the eye gaze. Now, you can try and fight them on that, but some DMEs aren't going to accept that in your report. So funding report. Remember that you do have to have goals in a treatment plan, and that's what we're really going to cover next time. Part 3 to this. You do have to talk about patient and family support. Do they have the patient and family support to be able to use this eye gaze accessory when you are writing for this type of funding? And the SLP and evaluation team has no financial support or connection to your DME supplier or provider. You have to state that in your report. Okay, so we're just going to look at just a few case studies, and we're going to talk about what was good, what was bad. We may not get to do every single thing, so bear with me as I kind of speed through this, and then I think we have one question that I haven't answered yet. Okay, so this was a denial. Mr. Doe is 25-year-old male. He has TBI. He's sometimes able to comprehend basic conversational speech. Expressively, he's unable to communicate. He's not motivated to communicate. He throws temper tantrums by flailing his legs to demonstrate when he's upset, but lacks the use of the means of useful communication. He's been receiving speech treatment for the last 6 months. Okay, and physically, he is not ambulatory. He uses a power wheelchair. He's often bobbing his head up and down and back and forth. He has movement in his arms and legs when he's angry and flails them about. So this has a lot of red flags, and let's identify what they are. So this is a good example of sometimes too much information or not enough. He's sometimes able to comprehend. Sometimes sounds ambiguous. Let's remove that word. He's not motivated to communicate. Well, guess what? You have to talk about how they are motivated to communicate. So if you put that they're not motivated to communicate, why would your funding source want to fund something? Okay? You talk about him throwing temper tantrums and moving his arms and legs, bobbing his head, but you don't explain anything else about that. So those statements kind of, the funding source could ask, well, if they're able to move, why are you recommending an eye gaze accessory? Okay? Receiving speech treatment, and that's all you say for the last 6 months. So you have to give them more information. That's an example of not enough. You have to actually say that the speech treatment didn't affect or didn't improve the communication impairment. So we took out, well, I forgot to take out sometimes, so we want to take out sometimes. And we talked about the times that he is motivated to communicate. So rather than saying across the board he's not, just say he's motivated to talk about food and entertainment, okay? Whatever does motivate the person. Remember to put that there was no improvement to their functional communication with the speech therapy. When you're talking about movements that they have, you need to talk about the difference between a volitional movement and one that's not. So in this case, he's bobbing his head up and down, and unfortunately, that happens no matter what he was doing. Despite that, he was a very successful eye gaze user, despite that bobbing of his head. And then with kicking his legs and flailing, he couldn't move his legs volitionally or on command. And so, unfortunately, that is not going to be an access for him. And he was able to get his eye gaze device. And I don't think we have very much time left to do any of the other case studies. I just wanted to make sure that I answered these questions before we end today. So the first one asked about the face-to-face note. Do they have to be for a specific length of time, for example, the last 6 months of face-to-face notes? Now, if your funding source requires that, yes, there is a length of time or a time requirement. And anyone can correct me if I'm wrong. I believe 6 months is what Medicare typically wants to have happen. I try my best to recommend that the person, when they get the referral for the speech order to get the evaluation, that same day they're doing the face-to-face note. And to me, that kind of ensures that I'm in the right time frame when I'm working with that physician and patient. But double check with your state funding source to make sure that you're correct on your timing. And also, if face-to-face notes were forgotten, so let's say the evaluation is done, the report has been done, the physician has signed off, but wait a minute, there was no face-to-face notes. You might be in really big trouble there, and it may vary where you are, what the consequence of that will be. But in Virginia, typically we have been able to go back and get that documentation needed, but it's always going to work more smoothly if you're able to get it in the beginning. It's a good question. Last question that I have I'm looking for a good eye scan evaluation site in Pennsylvania for my son. How do I find one? So not every single speech-language pathologist is well-versed in doing eye gaze evaluations, but you need to start with finding an assistive technology center or a place that is evaluating for AAC, that's Alternative Augmentative Communication Devices. And then once you find those places, check to see if they commonly do eye gaze evaluations there. That would be a good place to start. Another thing that you could do is you could check with your state assistive technology resource. Most states have some type of assistive technology resource, whether it's a loan closet that's done by state or whether they provide support to schools. But you could ask them, where are the sites in your state that these evaluations are typically done? So those are two things you could ask. And then if your son's school district has an AT specialist that works for the school district, you might have to ask the IEP case manager or the special ed teacher to put you in touch with the person who runs the assistive technology program, but they might be able to help you locate a place for that evaluation as well. Okay, so I'm just going to end this session with a review. Just be repetitive and descriptive in your documentation. Rule out other devices and accessories. Be informative in your writing. Check behind yourself to make sure that you've avoided any contradictory statements. You don't want to say that the person can write, but then later rule that out. Make sure that you know the report writing rules of your funding source. And don't forget to add your treatment goals, and we're going to talk about that more next time. Someone has just commented on that Pennsylvania question. They're saying in Pennsylvania, check with Easter Seals or Patton, and they spelled that P-A-T-T-A-N. So thank you for adding that comment. I hope the person who asked the question was able to stick around long enough to hear the answer. Thank you all for joining me today. I'm sorry we didn't get to the other case studies, but I'm sure that my slides are going to be sent out. And so if anyone has any further questions, I'll answer those. And if not, thank you so much. You've been a great audience. Thank you for all your feedback and comments and